Hi, everyone, and welcome to part 2 of our Geographic A Trivia series. And today we're going to be talking about beyond BCVA in search of better biomarkers for geographic atrophy. My name is Dr. Stephanie Wu, and I will be your host for this evening. And now it's my pleasure to introduce our speaker for this evening. Back by popular request, she has done several lectures for Wu Yu. We were just talking about how she did one on OCT, and it has by far been the most viewed lecture after an event has occurred. And there were so many testimonials about how amazing her OCT lecture was. So if you missed that, there were comments from people that said they learned more from Dr. Rodman than they did in optometry school in OCT. So I highly recommend you check that out if you are interested in OCT. So Dr. Julie Rodman is the chief of the Broward Eye Care Institute in Fort Lauderdale, Florida, and she's a professor of optometry at Nova Southeastern University. She's also the instructor of record for posterior segment disease at the college. Her research interests include OCT and OCTA, which she definitely is an expert in, and vitreoretinal disease. She's authored over 30 publications with an emphasis on retinal disease, and she's a member of AOA, AAO, FOA, and ORS. Thank you so much, Dr. Rodman, for being here. It's so nice to have you back to Wu Yu.
Thank you so much, Stephanie, for having me. It's such a pleasure always to be with you guys. These are my financial disclosures. None of them will affect the content of tonight's presentation. So as Stephanie, Dr. Wu explained, we are going to talk tonight about geographic atrophy. It has been really quite a year for geographic atrophy, so there isn't a better time to talk about this than now. So why is age-related macular degeneration such an important topic? And really the answer is it's because it is the leading cause of blindness in the developing world in our patients greater than 50 years of age. And now that there is so much awareness, particularly of geographic atrophy, we're finding more and more of it in our clinics. We know that 18.34, and this number is probably even greater now, of individuals in the US aged 40 years and older are living with the early stage of the disease, right? So that's crazy because we know that those patients are going to go on to develop intermediate and later stages of the disease. By 2050, that number is projected to be about 22 million. We know that about 1.49 million people in the US are living with the late stage of the disease, and that number is projected to go to about 3.8 million by 2050. So these are staggering numbers, again, emphasizing the importance of this lecture tonight. We also know that AMD is not a disease that is created equal. And what I mean by that is patients can have the early stages of disease, they can have the late stages of disease, and they can have a myriad or a variety of things that fall between the early and late stages of the disease. And we're going to talk a lot tonight about really differentiating between the different types of the disease, because as I said, picking up and finding this disease early is really going to alter and change the course of the disease. So for those of you that know me and know the way that I like to lecture, it's very important to always go back to anatomy. You have to understand what part of the eye, what part of the retina is affected in various diseases to really understand it. So when we look at this kind of histopathological slide of the retina, when we think about diseases like diabetes, we're really thinking about, diseases that affect the inner or superficial part of the retina. But in age-related macular degeneration, this is the disease that affects the outer retina. So essentially my purple little hash line there is showing you what the cutoff is for a patient that has age-related macular degeneration. So we're dealing with photoreceptors, retinal pigment epithelium, Bruch's membrane, choroid. So when you're talking particularly about OCT, let's say, we want to look at the area of the OCT that's primarily going to be affected in this disease. So here's a perfect example, or a transposition, if you want to say, of that histopathology slide onto an OCT. Where are we exactly looking? So, are we emphasizing neurosensory retina? Not so much. Again, those would be diseases like diabetes. But in AMD, we're looking at this area with the purple arrow here. So essentially our photoreceptors, or our photoreceptor integrity line, our retinal pigment epithelium, Brooks membrane, choriocapillaris choroid. And we're not going to spend a ton of time talking particularly about OCT tonight. You can go back and watch that lecture, but really understanding that this is the area, this is the hot spot of where you want to be putting your attention in age-related macular degeneration. We also know that this is a disease that is characterized by drusen. Drusen is the hallmark that leads to all of the sequelae in this disease. The drusen is what's going to eventually lead to the progressive degeneration of the outer retina, which, as I mentioned, is the photoreceptors RPE Brooks membrane choroid. And on this depiction, or on this picture on the right here, you can see these drusenoid deposits that are living between the RPE and Brooks membrane. And again, these are going to be the problem that leads to all the sequelae in this disease. On an OCT, regular drusen, which is most of the time what we see, likes to live between the RPE and Brooks membrane. You'll notice these bumps, and they're pretty homogeneous on the inside, meaning that the color of them is hyperreflective and fairly uniform throughout. That is what we're looking for in age-related macular degeneration. Remember that this is a disease that is irreversible and 100% progressive. So looking for these drusen and understanding that patients that have drusen are likely going to go on to develop later stages of the disease. So I want to just very quickly discuss risk factors for AMD, because I think it's very important when you're differentiating between patients and trying to figure out which patients need more attention than others. So I love this little picture of this little old lady who's over 100 years old, who is smoking and probably has AMD. So we know that in any disease state, there are two types of risk factors. We have non-modifiable risk factors, which are ones that we essentially are born with, things that we cannot control. And the number one non-modifiable risk factor in AMD is your age, right? We know that you get older, just as the name implies, and you're at risk automatically for getting this disease. So it is the number one non-modifiable risk factor. And if you look at this next line here, individuals greater than 85 years of age are 10 times more likely to have late AMD than those in their 70s. And that number continues to quadruple every couple of years. So again, age very, very highly correlated with this disease. We know that race, right? We know that Caucasians are much more prone to getting this disease. This is a disease of the white people. Genetic factors. There's so many genes that are implicated in AMD. Particularly, we look at the complement gene, we look at the ARMS2 and HTRA1 genes, but there's tons and tons of genes implicated. And then family history. Patients that have a positive family history, 50% lifetime risk versus only 10 to 12 without. So big, big issue. We get patients all the time that come in and say, my mom or my dad went blind from this disease, and they're worried about it, and rightfully so, right? This is something, like I said, that runs very high in families. The other type of risk factor is the modifiable ones. And I would argue that our job as optometrists is to really focus on these modifiable risk factors, because these are the ones that we can change or we can alter to make the course of the disease less, or let's say slow down the course of the disease. So we know smoking, the number one modifiable risk factor. Smokers are 4 times more likely to have AMD than non-smokers. And not only are they more likely to have it, but they're more likely to get it earlier than patients that didn't smoke, and they're going to have more advanced stages of the disease as well. We know that poor diet is huge, right? The patients that walk around the inside aisles of the supermarket, which I'm guilty of as well, the ones that like to get the box food, the cookies and the chips, that's the problem, right? Eating things that are not in the produce section, looking for adding more color and more variety to our diets. Not getting enough antioxidants, vitamins, minerals, thus the use of supplements and nutritional supplementation. We also know that high alcohol intake, greater than 20 grams a day, is not a good thing. A little bit of alcohol is okay, but once we get past that number, it tends to not be good anymore. Obesity, cardiovascular disease, very big correlation between, high cholesterol, arteriosclerosis. And then sunlight exposure, which is huge living in South Florida. And I get asked this a lot, if I'm outside for a little bit of time, is that putting me at risk? And really the studies have shown us that you have to be outside for quite a while. So if you're a roofer or you're working construction, for more than 8 hours a day, those tend to be the patients that are most at risk of having this increased sunlight exposure. So these are the things that we want to discuss with our patients wearing sunglasses, modifying their daily routine. And this is really just a summary of how important genetics plays in this disease. We know that genetics itself has about a 70% contribution to this disease. And the reason being, if you look in detail here, that the genes or the genetic profile is the thing that sets off the cascade of drusen formation, which leads to reactive oxygen species, this increased inflammatory response, which is then when our complement system is going to kind of act up. And we're going to talk about that later on in the presentation. 30% of the contribution is everything else, which we talked about. And you can see, I'm not going to read these, but all of the other things that we talked about. So really a huge part of this disease is just luck, right? Having that genetic predisposition or that genetic profile that puts you at risk of developing this disease. Okay, let's jump into the pathophysiology. This is super important as we move through towards some of these identifiable risk factors and things we're looking for. So this is a really pretty picture that was given to me by my friends at Maculogics many years back on what the eye or the retina really looks like, the outer retina. So essentially we have the photoreceptors here, we have RPE, we have Bruch's membrane, we have choriocapillaris. And what I like to say is that when all of these parts of the retina are working properly, the retinal is going to look fantastic, right? Everything's going to look healthy. Remember that within the choroid, we have nutrients, we have things like vitamin A, and vitamin A has to get through Bruch's membrane to get through to the RPE. And vitamin A is needed to convert rhodopsin for our ability to see dark. So if there's something building up or there's something going on within this area that's not allowing vitamin A to move up into the higher levels of the outer retina, there's going to be a problem dark adapting. There's going to be other symptoms that maybe we don't think about as being correlated with AMD. So keep in mind that each of these layers of the outer retina has a purpose. And when they're not working properly, patients are going to have symptoms and clinical findings that correlate. So as I've mentioned many times already, the first thing we're going to notice in AMD is this drusen deposition, which we like to call cholesterol buildup along Bruch's membrane. And what you'll appreciate now is that if there is this vitamin A or these nutrients in the choroid that are trying to traverse over Bruch's membrane into the RP, becomes very difficult when there's these speed bumps that are not allowing these nutrients to get where they need to. So you can appreciate in this picture that Bruch's membrane, I'm sorry, not Bruch's membrane, the RPE is not looking as healthy as it did in the previous picture. But keep in mind that even when a patient has this early buildup of drusen, we don't see anything funduscopically, okay? The drusen has to be large enough in size, which I'll show you in just a minute, for it to actually appear clinically. However, there's going to be early signs of degenerative disease going on because the patient might be complaining about some inability to dark adapt due to that nutrient deficiency. You can notice here that as the drusen continues to build up and continues to kind of saturate Bruch's membrane, you can see that the RP is really dying there. The RP is losing that healthy appearance that I showed you on the first picture. But the really sad thing here is that clinically, we're still not going to see anything. Thus, again, arguing to the importance of asking specific questions to the patient. Once the drusen gets big enough, so here you can now see a full drusen formation or the coalesced appearance of that drusen deposition. This is where there is big time death to RPE. Look at how thin it has become. The photoreceptors almost look skeleton-like, and this is where you're finally going to begin to see drusen deposition on the retina. But think about this cascade of what has happened in order to get to that point where the drusen is actually clinically visible. So much that we need to kind of do as far as talking about those modifiable risk factors so that we don't get to this stage of the disease maybe as early as perhaps we would have. So, there are many classifications of AMD. I prefaced at the very beginning of this lecture that not all AMD obviously is created equal. There's many stages. And the one that I feel is most broadly accepted is the Beckman classification, or that's the one that at least that we use at the university. And this puts AMD into 4 categories. So I'll talk about them briefly, starting with no AMD. And you're probably wondering why there's a category called no AMD, which is defined as no drusen Or if they do have drusen, they're going to be small drusen, which mean less than 63 microns. And really the answer to that is that a lot of patients have really tiny drusen in the retina. And we want to be careful not to give everybody this classification of AMD. It's okay to have one or two or three, some small, really hard little tiny drusen going on without them having AMD. So very important to understand that drusen does not always equal age-related macular degeneration. The first real category, I would say, is called early AMD. And early AMD just basically means that you have medium drusen. Medium drusen are defined as 63 to 125 microns. And it's a good idea when you're first learning to assess drusen size to either use OCT or look at the size of a vein to kind of understand what you're looking at so you can appreciate what stage of the disease you're at. It's also important to note that in the early stage, there's no pigmentary changes, because remember from the pictures I just showed that once the RPE begins to degenerate, you're in a later stage of the disease. So if the RPE is maintaining its integrity, we're still very early on in the disease process. In the intermediate stage, you need to have at least one large drusen. So what you're going to notice is that as these stages progress, the drusen are going to get larger. And there may be now evidence of pigmentary abnormality, which again is an indication that that RP is kind of atrophying, it's dying, it's shedding itself. And then we get into the advanced stages, and we know that there are two types. We have the dry advance, which is geographic atrophy, and we have the wet advance, which is neovascular AMD. And we'll talk a little bit about each one of them, but the focus of the rest of this conversation is going to be primarily on GA. I think it's also important to recognize that fundus autofluorescence is extremely important for AMD because the FAF looks particularly at the RPE. So the RP is made up of lipofuscin, which is a fluorophore, and fundus autofluorescence is going to look at the health and integrity of the RPE by fluorescing the lipofuscin. So anywhere where you have lipofuscin, which is essentially the RPE, you should get what we call this autofluorescence. When you have no lipofuscin, it's going to be hypo or dark, meaning there's been atrophy. When you have kind of a metabolically active RPE, meaning that it's on its way to dying, you're going to get brightness or hyper autofluorescence. So, notice that the optic nerve blood vessels are dark because there's no lipofuscin within them. The macula is normally dark because of carotenoids and increased pigmentation. But once again, looking at patterns of fundus autofluorescence is extremely important in AMD. And in fact, when you ask some retina specialists what their imaging modality of choice is, I would guarantee a lot of them would say FAF, just because it's very easy to pick up subtle areas of geographic atrophy on FAF. Patients that have no AMD are going to have obviously a normal FAF. Just to kind of go back over these stages for a minute and show you the fundus autofluorescence and OCT of each of them. For early AMD, remember, we're looking for medium drusen without pigmentary abnormalities. So clinically, this is what it might look like. Pay attention to the size of the drusen. What you'll notice here is that the drusen are present. They're not tiny, but they're not extremely large. And there are no pigmentary changes here. On OCT, you'll notice that there are these tiny little undulations here between the RPE and Bruch's membrane. They're not very big, but they're definitely present. In a patient that has very, very tiny drusen, I would argue that a lot of times you won't even see them on OCT. They're so small. So once you're in that early stage, you're going to see them on OCT, but they're not going to be extremely dramatic in appearance. FAF may or may not show anything in the early stages. You may see some hyper autofluorescence, which if you're looking very carefully, you may see here showing that there is some variations in the lipofuscin or some variations in the health and integrity of the RPE. Remember, in the intermediate stages, the drusen are going to get larger. So we're looking for at least one large drusen with or without the presence of pigmentary changes. This is clinically what it might look like. You can appreciate that there is a large drusen, probably more than one. You'll also appreciate that there's a pigmentary change right here. So you'll notice how this patient looks much more, along the road than the early AMD patient did. If you didn't notice that, if you do the OCT, you'll certainly appreciate that we can now call these almost drusenoid pigment epithelial detachments. The drusen has gotten large enough now that the RP is actually lifted up. The other thing you may notice are these little hyper-reflective areas. living right near the RPE, which is suggestive of pigmentary changes that go along with the intermediate stage of the disease. And we'll talk about that later as well. Fundus autofluorescence, also, you'll notice these hyper autofluorescent areas, maybe some hypo autofluorescent areas, indicating again changes in the RPE. In the advanced stages, we have geographic atrophy and CNV. Just really, really briefly, geographic atrophy is going to be a loss of that outer retina. So loss of our photoreceptors, loss of our RPE, loss of our choriocapillaris. When you strip those tissue away, you end up visualizing down to the lower layers of the retina. So here, of the choroid, I should say, you see choroid here, choroidal blood vessels, usually a very well circumscribed area. And on OCT, you'll see here that there has been a stripping away of that outer retinal tissue. In fact, the neurosensory retina looks like it's collapsing down as well. And we're going to talk about this, but we get almost a transmission defect into the choroid because of this missing tissue. Choroidal neovascular membranes, we're not going to spend a ton of time on, but we all know that that is a hyperreflective area on OCT. All right, so let's switch gears now, particularly looking at geographic atrophy, because that's what this lecture is intended to be. And I like to say what a year it has been. It has been a phenomenal year in advancements and development in geographic atrophy. A couple of things to keep in mind. GA actually begins parafoveally. You know, in school, when we were taught about geographic atrophy, we were taught to look for something like this, you know, this big lesion affecting the fovea. What we're learning now, and I think the emphasis of GA really needs to be starting to look for these more subtle signs so that we can pick up on these signs before they actually begin to encroach upon the fovea. You know, once they do, that's when our patients are going to become most symptomatic. We know that GA is mostly bilateral. It may be asymmetric, but once one eye is affected, the other eye is likely going to follow suit. I like to ask this question. This was a question that was given to me by my friends at Astellas and Modern Optometry. But, you know, what do states like Philadelphia, San Antonio, or cities, I should say, San Diego, have in common with geographic atrophy? And if we were together in a live setting, I would let you answer. But these are the population of these states. And I think some of these, I should say, cities, states are pretty large. That's the number of people with geographic atrophy. And that number is about 1.5 million people, which is a huge number. And I'll also throw out there that remember that these are the diagnosed patients. So arguably, this number is actually much larger than 1.5 million. So the new medications that have come out in the last year are work on what we like to call the complement cascade. And I want to just talk about this very briefly, and I'll bring it up at the end again. But we all have a complement system that is intended to protect us. What happens in geographic atrophy is there's actually an overactivation in the complement system. So when you look at this picture of this complement cascade, they all merge upon something called a membrane attack complex. And when there's overactivation of this complement cascade, that membrane attack complex goes into high gear and starts to cause damage to the retina. So the idea with these medications, and this is a very busy slide, but the idea is that we want to try to dampen down some of this overactivation of the complement system that happens in geographic atrophy. And I'll get to that later on as well. Okay, so my favorite part of this lecture, really the imaging modalities. How can we do a better job at identifying patients early on in the disease so that we can change the course of their disease? And we know that within our practice settings, we all have different imaging modalities, and each of them has its strengths. Each of them have, things that they do better than others. And probably in the ideal setting, we would have the option or the availability of using all of these modalities. But we'll touch on a couple of them here just to talk about how you can pick up on early signs of GA in your practice. So using color fundus photography, fundus autofluorescence, OCT, and NIR. So color fundus photography really is probably, if I were to ask every person here what imaging modality they have in their practices, everyone's going to have a color fundus photography machine. And they're really excellent at picking up the more obvious signs of geographic atrophy, sometimes not the best at picking up some of the more subtle signs. We know that color fundus photography is excellent because it allows us to visualize, these well-circumscribed areas of GA. It's very good at picking up drusen. It's very good at looking at change over time. My problem with color fundus photography is sometimes very early or very subtle signs of GA are sometimes a little bit difficult to see on color fundus photography. So using it as a baseline, using it as something that you can kind of look at over time is helpful, but keep in mind, it's not going to be the 100% perfect diagnostic modality. OCT has been recognized probably as one of the best ways to visualize geographic atrophy. And there's actually certain features that can be found on OCT that will highlight or tell us that a patient is going to move at a faster rate than others. So remember, just keep in mind that we're looking at the photoreceptors, RPE, Brooks membrane, choriocapillaris, putting attention on that outer retina. So one of the things that we want to look for is something called choroidal hypertransmission, and I kind of alluded to this before. So remember that if you have an area where there is loss of photoreceptors, loss of RPE, thinning of Brooks membrane, all of the reflectivity that essentially lives in the area of the RPE is no longer going to be there. So what you end up seeing is the light is now going to sink down into the choroid and cause what we call choroidal hypertransmission. Looking for, this is a very obvious picture of a very large area of choroidal hypertransmission. However, if you look at these OCTs and you look very carefully for areas where we see these pillars of hyperreflectivity, that's actually an excellent way of picking up very early signs of geographic atrophy. And we have the ability now, we always have to, either you get a raster or a line scan, you can go directly through various layers on your color fundus photograph, and you'll actually be able to pick up these very subtle signs on OCT. So looking for what we call choroidal hypertransmission, and it might be something very, very tiny, like a little line, a little vertical line in a very early area of geographic atrophy. Here's a nice example of a patient that has these, two large areas of GA, and particularly looking at the OCT where these white arrows are, you can see that there is really no RPE and there is increased choroidal hypertransmission in that area. Here we have large drusenoid PEDs or pigment epithelial detachments, but from this white arrow to this white arrow and even beyond, you can see that there is no RPE and there is choroidal hypertransmission. Another thing that you might appreciate, or what you should appreciate on OCT that is associated highly with advanced disease, is something called reticular pseudodrusen. So I mentioned before that regular drusen, and I can go back here, live between RPE and Brooks membrane. There are these homogeneously white areas of elevation pushing up on the RPE. Reticular pseudodrusen, also called subretinal drusen, don't respect those lines or don't respect that definition. So what I mean by that is that the drusen actually go above the RPE into the subretinal space. This one would be a regular drusen. This one tends to peak up high above, really into the photoreceptor layer. When you have patients that have these reticular pseudodrusen, they are more at risk for developing advanced disease. They're more at risk of progressing at a faster rate. This is another nice kind of schematic. You can see how they have this very triangular appearance and they go above the RPE, almost like sawtooth projections. So hopefully when you go back to clinic tomorrow or next week or whenever you're there, you'll start to look at OCTs in a different way. Just a summary, this one here, these would be regular drusen. These over here that kind of look like sawtooth, look more triangular. Those are the reticular pseudodrusen. So again, advanced progression with those. Other things, which I also showed before, the hyperreflective foci. Hyperreflective foci are an indication of pigmentary abnormalities. That hyperreflective coloration is because it's coming off of the hyperreflective RPE. It is pigment that has migrated off of the RPE up into the higher levels of the neurosensory retina. Once again, an indication that the RP is no longer healthy, right? Once the RP begins to migrate, we know that it is no longer healthy. There's also some, on the bottom here, these little hyperreflective foci here, those are pigment that have broken off of the RP and have dispersed up into the neurosensory retina. So again, looking for those that is an indication that there will be more advanced or rapid progression of the disease. Look at the size of the drusen. I mentioned before, then the Beckman scale, as the disease continues to go through stages, the higher and taller drusen are going to be, more correlated with more advanced stages of disease. Also looking for discoloration, or I shouldn't say discoloration, but non-homogeneous drusenoid pigment epithelial detachment. So if you have a darker area within the drusen, that's an indication as well that this drusen is not a healthy drusen and is going to go on to progress at a more rapid rate. Also looking for what we call subsidence, meaning sinking in of the outer plexiform and internuclear layer. So you can kind of see this kind of sinking in effect, which we also called hyporeflective wedge-shaped lesions, also called gull wings. These are all indications that that neurosensory retina is beginning to collapse down into these areas of geographic atrophy. So looking for all of these indicators, and once you see them, you won't miss them, but now at least you'll know what to look for. Something else I'd like to throw out is if you see something that looks like the eye is getting better, be careful. You can see here on the NIR image on the left that the drusen definitely look worse from point A to point B. However, if you look at the OCT, the drusen look like they have collapsed. Drusen collapse is actually an indication that the geographic atrophy is, or the AMD is getting worse, not better. Drusen do collapse over time, leading to the development of geographic atrophy. So something else that you should keep in mind if you started a patient on a nutritional supplement and thought maybe they were miraculously doing better, think again, particularly if you look at the NIR image or the FAF or other image that shows the opposite. Fundus autofluorescence, I mentioned before, an awesome imaging modality. What we're learning about fundus autofluorescence with GA is that if you look at the junctional zone, or the area between healthy and not healthy retina, meaning you're looking at the boundary between healthy and unhealthy retina, you can learn a lot about how fast the disease is going to progress. So we know that GA is going to be dark. GA is going to be hypoautofluorescent. But what does it mean when patients have different types of reflective pattern around the geographic atrophy? Well, if you look at the three boxes with the arrows or the exclamation points, those three patterns, the banded, diffuse, and diffuse trickling patterns, are most suggestive of the most rapid advancement of the disease. So if a patient has no junctional zone, meaning there's no hyperautofluorescence, or focal areas, just little spots or patchy areas, those patients are not going to progress as rapidly as patients that have this hyperautofluorescent area in the junctional zone. So if you're using FAF, hopefully now you'll look at it in a different way and start looking at that area. What about patients that have foveal versus non-foveal lesions? You know, if I were to ask you which one is going to progress at the more rapid rate, maybe you thought, I mean, before I started learning about this, I thought the foveal would progress rapidly, more rapidly, but it's actually not. If you look at this, foveal on average grows about 1.28 millimeters squared a year, whereas non-foveal grows about 2.05 millimeters squared per year. So what I mean by that is if you look at the lesion, and these are FAF images, is the lesion in the fovea? Is the lesion bordering the fovea? If it's bordering the fovea or outside the fovea, those tend to move at a faster rate. This is a patient here that has many hypoautofluorescent lesions, a huge one here and lots of little ones, but the fovea looks spared. This patient does not have a good prognosis. This is a patient that likely is going to move at a pretty quick rate. Also looking at how many lesions there are. You know, is there one big lesion or are there many small lesions? Patients that have many small lesions, also called multifocal, are going to move at a faster rate than if they just have one lesion. So, you know, going back to this patient here, not only is it non-foveal, but it's multifocal. This patient doesn't have a great prognosis moving forward. Lesion size, it would make sense that a bigger lesion is going to move quicker than a smaller lesion, right? So taking all of this into account will help you to determine, you know, is this a patient that I want to send out this week for intervention? Do I want to wait and watch them a little bit? Thinking about all of these things will help make that decision. Patients that have a lesion in one eye more likely to go on and develop a lesion in the other eye. Looking at NIR, also called near infrared reflectance, not to be mixed up with fundus autofluorescence. This is the type of picture that is taken alongside an OCT. So that is not a fundus autofluorescence image. NIR is nice because it has a higher wavelength than FAF images, which means that the light can penetrate through the RPE. So I said before that FAF really focuses on RPE lipofuscin. NIR goes way down past the RP and allows us to visualize all the way through into the choroid. So what you're noticing here is that the FAF images are on the left, NIR images on the right. And there you can see it's almost like black versus white because the NIR is able to penetrate through the RPE. So geographic atrophy is actually going to be white on NIR imaging. And it does a really, really nice job at, identifying reticular pseudodrusen. It's NIR is a great imaging modality, also kind of highlights the lesion very precisely. But just keep in mind that it is going to be the opposite of what you see with FAF. Okay, so let's look at a couple of cases here. This was a 73-year-old Caucasian male who came in for a comp, and notice his history is very interesting. He said that he was having difficulty seeing at night. And remember that we oftentimes think about this age group and we say, well, 73-year-old, he's got cataracts. Of course, he can't see at night. But hopefully after tonight's presentation, when you hear this complaint about night vision problems, you'll also start thinking about age-related macular degeneration, particularly because of what I mentioned before with this trouble with vitamin A and rhodopsin conversion. He's also reporting pinhole black spots in his vision. For his medical history, remember he's 73, he's Caucasian, so he's got some risk factors going on there that are non-modifiable. For his medical history, he's a smoker. Not only is he a smoker, but he's a 40-year smoker and he's still smoking. So this guy has got, a lot of marks against him. He also has a family history. And remember that these patients have, a much greater lifetime risk than patients that don't have a positive family history. So just going into this to start, this is a gentleman that's got a lot of strikes against him. And, these fundus images really highlight what I was talking about before with color fundus photography. Despite the brilliant images and the clarity of the images, when I first saw the patient, I wasn't thinking geographic atrophy, 20/30 in the right, 20/20 in the left. And I kind of want to break down what I thought about these pictures very quickly. But, the patient has some modeling right in the macula. He's got some scattered drusen. But the thing of interest here was that he had these big areas of whiteness, if you want to say. And at first I'm like, what am I seeing there? And the more I looked at it, the more I realized that this patient actually I should have had areas of a non-foveal involving geographic atrophy. His left eye had some drusen, different size drusen. What type? I would probably argue it's early to intermediate. I didn't see any evidence of GA in that eye. And this is really a highlighted picture of that color fundus photograph and how easy it is to miss geographic atrophy, really identifying and being careful. And when I took a line scan directly through the area of interest, you'll notice here how the patient has a couple of things. He's got a big hypertransmission defect. Notice that the RPE photoreceptors are missing here. Notice the gull wing, the substance of the ONL and IPL kind of sinking down into that area. So when you look very closely, this patient's 20/30. Why? Because the fovea is spared. He does probably have a cataract. He does have some modeling, but this is not a center involving, or I shouldn't say, it's a foveal involving geographic atrophy. If you're not looking for it, you certainly can miss it. There's that OCT just highlighting what I just said. This was a change analysis. I saw the patient 1 year apart. I want you to appreciate this is the newer scan. This is the older scan, the NIR image. Notice the size of the choroidal hypertransmission, how much bigger it went from here to here in this location. So in a 1 year, a little less than 1 year period, this patient had significant, advancement in the disease. This is the fundus autofluorescence. You can appreciate the junctional zone here. Definitely has what looks banded, which is definitely going to move quicker. And again, here's just the kind of that summary before. It's multifocal, it's extrafoveal. He's got the banded at fundus autofluorescence. He's got all these strikes against him, showing that this is likely going to rapidly progress. And here is the patient 2 years later. You can appreciate on the color fundus photography, the difference between, here and here. Look at now, it's almost looks like a big ring around the fovea. And you can see on the fundus autofluorescence that this is encroaching upon the fovea in a 2 year period of time. And just to mention also, it takes about 1.5 to 2.5 years for this GA to become or to encroach upon a fovea that has extrafoveal involvement. The other eye, this is just showing you he looks like a reticular pseudodrusen here, probably in the early intermediate stage in this eye, and just more of a magnified view of the better eye. And the change analysis as well on this patient 1 year later, not as much of a significant change. You might appreciate that the drusen in 2022 has collapsed in 2023. Remember that that's an area that likely will turn into geographic atrophy at some point down the road. So be careful not to give your patients ill hope if you see drusen collapse. And here is the patient's better eye, really picking up on fundus autofluorescence, perhaps some early areas of hypoautofluorescence that might be some early geographic atrophy as well. So really, hopefully you're seeing with these different imaging modalities that each of them is able to identify something. You know, looking back at this picture in 2023, there actually looks like there might be some very subtle areas here of geographic atrophy that I might not have picked up on if it wasn't for the fundus autofluorescence. Let's look at another case. This is an 86-year-old Caucasian female who comes in for a comprehensive and she's having difficulty driving. Her medical history, she has high cholesterol. We talked about, you know, cardiovascular health. She's got high blood pressure. She has a positive family history. And she's a passive smoker, which is always so entertaining. You know, what does that mean, passive smoker? So she's got a lot of risk factors here, and she's 83. On initial presentation, here's her fundus autofluorescence. She definitely has some drusen. You can see the difference in reflectivity here. She's got some darker areas as well that I would keep an eye on in this parafoveal location. Of note on the OCT, she has some reticular pseudodrusen. Notice these tall, sharp drusen. You know, this is kind of going through just to show you how rapidly this progressed. You can see her baseline FAF, and 7 months later, look at the difference in the size of these areas that I told you I would have kept an eye on. You can see here how these areas have gotten significantly bigger. Look at this in 1 year, 8 months, in 2 years, 3 months. Look at these lesions. Look at how these areas of hypoautofluorescent have changed in a 2-year period, you know, from this at baseline, which maybe you wouldn't even have appreciated or called it geographic atrophy, to what's happened in 2 years, 3 months. And this is multifocal, non-foveal lesions with surrounding drusen deposits there. Look at what happened at 3 years. She now has these huge areas of geographic atrophy. And what you'll appreciate in this little picture on the right is that she now has scotomatous areas right in the center of her vision, correlating with these areas of geographic atrophy. So if I can highlight one thing, look at the baseline FAF here and look at what happened in 3 years. I mean, that is how rapidly these lesions progress. What happened in 3 years? There's the two of them side by side. It's really pretty dramatic. I mean, I think fundus autofluorescence is a phenomenal way of showing a patient exactly what's happening. The OCT, you can see the baseline and 7 months later. To me, not as dramatic. Definitely reticular pseudodrusen, definitely some choroidal hypertransmission defects, just not as dramatic as the FAF. You can see her over time, what's beginning to happen. Notice these skinny areas of hypertransmission. That's what I was talking about. That is the subtle early signs of geographic atrophy. At 2 years, though, look at the difference in the size of the choroidal hypertransmission. You can see there's definitely been a change. At 3 years, it's obvious now she has no RPE left, large areas of reticular pseudodrusen here. She's got some subsidence of the INL and OPL. So crazy again, and you can see here both imaging modalities side by side, how things have progressed in about a 3-year period of time. Okay, and then we have, this is just a patient here. I'm going to try to go through this quickly so I can get to the treatments, but an 82-year-old Caucasian female who has a complaint of decreased vision, also difficulty with low light vision, similar to, you know, night vision complaints. And she reports her vision is overall worsening. And just to show you, this is an ideal candidate here. This is a patient who has large confluent drusen. She's got pigmentary changes here. You know, this is a patient that is going to go on to develop geographic atrophy. This is somebody who we want to watch very closely for any development of atrophic changes. Here's her fundus autofluorescence. I don't believe at this point in the game there was any geographic atrophy, but definitely there was a lot of changes in the autofluorescent pattern from these huge drusen and pigmentary changes. Here are the two imaging modalities side by side. For OCT, notice some of the markers we talked about. Look at the size, the height and width of the drusen. Look at the hyperreflective foci. Remember, that's an indication that there has been pigment migration. There's also variability in the color or the dome of the drusen. Remember, we talked about that when it's non-homogeneous. That's an indication that these drusen are going to move at a rapid rate. This is her other eye, similarly, very large drusen. I don't see any pigment changes in this eye. Here's the FAF. Remember, hyper autofluorescence is going to go on to turn into hypo autofluorescence over time. The two imaging modalities side by side, and here's the OCT of that left eye. So management decisions, I really wanted, this is the drive home point of this presentation, when is the right time to think about sending these patients for intervention? And I would argue that as soon as you see any signs of geographic atrophy, it's not our decision to make when the injection should happen, but certainly we want to make sure that our patients are taken care of at the earliest possible time, because that is when their outcome is going to be the best. And just historically, a year from today, what did we have available? Really nothing. We lifestyle modification, supplementation. Now we have options. We have options that work on our complement system. We have Syfovre, is made by Apellis, which works on the C3. I'm not going to go through this in a ton of detail, but that's where they stop the complement cascade. And then these are some of the data on Syfovre. When given every other month, it's about an 18% reduction in size of the geographic atrophy. I just want to rewind and say that these medications do not reverse the disease. They don't get rid of the disease, but what they do is slow down the rate of growth, giving patients longer to live with the vision that they have. When given monthly, it's about a 22% reduction. And then we have Astellas makes Izervay, also Iveric Bio, Astellas, same company. They work on C5. Their numbers here you can see about 35% in the GATHER1 trial, about 18% in the GATHER2 trial. And just keep in mind that these medications are extremely safe, extremely, effective. And something that we want to also keep in mind and tell the patients is that these are medications that you kind of have to be committed to. Once you start taking them, you need to continue to go back and continue to take the medications. It's not a one-shot deal. But what I hope you learned tonight is that there are a lot of things that we as optometrists can do and look for to pick up signs of the disease as early as possible so we can get the patient where they need to be.